Okay. All right.
Not the
welcome,
eraser.
everyone.
It's erasable.
It's a pleasure to see you.
It's like
Also to see sprinkled in the audience, friends. My name is Steve Berman. I'm the director of the Center for Global Health and a pediatrician who's practiced with a lot of people in this room for a very long time. And it's really my pleasure to introduce Janine. It's interesting, usually I say we should have very short introductions, but I was reading the evaluations from the course on global health, and they said, we need to know about the people who are talking to us. Please let us know a little bit about them. So I want to tell you a little bit about Janine. Janine's the medical director of the Denver Health Refugee Clinic and the co-medical director of the Human Rights Clinic at Denver Health. And she serves as the medical advisor for the State of Colorado Refugee Services Program. Janine picked out this area of pediatrics some time ago. And what's been really so impressive is that she's been able to be such an effective advocate, not only on the local level, but really the national level through her work with the American Academy of Pediatrics. And it's clear over the last 6 months or more how important it is to have advocates for this issue, given separation at the border, given being lied to about whether it was policy or not, and basically the human rights violations and the violation of, even though we're not a member, the UN Convention on the Rights of the Child, how we've really been in a situation where not only have we not signed it, but we've really been in, I want to say, against what that whole document was about in terms of our actions. So Janine was an undergraduate at Columbia. She received her medical training in Boston. I'm not going to say because people who went to Harvard never like to say Harvard. And she did her pediatric residency training in the Boston Combined Program and UCF Benehoff Children's Hospital. And I can say she's a superb pediatrician with a lot of passion, and it's a pleasure to have you give us this talk.
Thank you, Dr. Berman. I really appreciate it. So I don't have a mic. Can everyone hear me? Okay. First of all, I just want to know who's in the, I know a lot of people here, but who's here? So how many physicians are in the audience? Okay. How many public health people, MPH types? How many nurse practitioners, PAs? Social workers, psych, couple, researchers we have. Any other groups that I'm missing? I just want to know who I'm talking to. So it's really, thank you so much for that introduction, and it's really a pleasure to be here. I have no relevant disclosures. So the goal of this talk is to give a very brief overview of U.S. refugee resettlement demographics. But the real goal is to describe the formal refugee resettlement process using the Burmese population as a model. And we have Burmese here living in Colorado, and we'll go over that. I'm looking at the eastern side of Burma and the Thai-Burma border, and I'll show you a map because I know a lot of us are geographically challenged, including myself. I am not going to be talking about the Rohingya population, which I assume everyone has heard about in the news. It's another crisis population, but this is not where I went to work. We have a very small population of Rohingya refugees who have resettled here. They are extremely discriminated against, but it's not a game of discrimination and level. I'm going to talk about International Organization of Migration Exams, which is a UN entity, and this is what I had the opportunity to do in August, is to work with IOM in Bangkok and the Thai-Burma border. And I'm also going to talk about the overall population health on the Thai-Burma border and how that affects sort of what we're doing with screening here and sort of how to take a step back and sort of look at these populations. and also what we do very briefly with what we do with screening when we do resettlement examinations. And if you have questions as I go, please, this is a relatively small group, please raise your hand. I don't mind questions at all. So I had permission to use this picture. I spent about a month on the Thai-Burma border and in Bangkok and went to the largest refugee camp in Thailand. It's called Mae La Refugee Camp. And the day that I got back, I went into my clinic at Lowry Family Health Center. This is the first family I saw. I know them well. They're from the Mae La Refugee Camp. The woman on the left speaks fluent English, and we had a long conversation about how I had just come back and what it was like. And it was an incredibly intense, amazing thing to do. So I want you to keep in mind that those patients, because I can give you stats and we can talk about numbers and graphs, and these get kind of boring, but all this comes back to the patients that we see at Lowry, at Denver Health, at Children's Hospital, and all the clinics around. I think this is probably one of the best graphics out there because it gives a geopolitical history of what we have done and where we currently are in refugee resettlement. And it goes through, if you look at the red up in the left, and if I don't know if there's a pointer around here. It's okay. So if you look at the left in the red, you have Asia back in 1970s, Vietnam. We have former Soviet Union going over farther to the right-hand side. But this also gives the refugee ceiling of admissions, and this is by presidential decree or determination. And you can see this is up to 2019, and you can look at that little blip. We're at the lowest level of refugee admissions since we've recorded in 1975, and probably one of the worst refugee crises in the world since World War II. So I want you to take a step back and think about that and put it into perspective. I hear the word refugee used a lot, but it's a legal term. So not every immigrant is a refugee, and it takes much work, and I'll go through this, to get refugee status, legal status to stay in the United States, to get health insurance, to have access to WIC. Other immigrants don't have that, and Dr. Berman mentioned most of our unaccompanied children from the Northern Triangle countries of Guatemala, Honduras, and El Salvador don't have refugee status. So again, this is a legal definition, and it's someone who is unable or unwilling to return to their country of origin owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or a political opinion. And it's definitely a political designation as well. Haitian refugees are not refugees, they're immigrants. And all is politics, unfortunately. This is the best infographic I think that exists, and it's from the New York Times, and it goes on and on. And actually, I cut it off, but it is the long road to how you get refugee designation. This is not an easy path. This is a path that takes years. And so the way this goes is you happen to be from Burma, you flee to the Thai border, you register with the United Nations, which is the International Organization of Migration, you interview, you get refugee status, you get a referral to the US or several other countries that are still accepting refugees, which are not many. Canada is the largest, UK very small, Australia, New Zealand, very, very small numbers. You interview with the State Department, you get your first background check, you get a possible higher level background check. This is actually published pre-new president, and so there's more steps in this. Another background check, fingerprint screening, okay, et cetera. You finally get down to the cutoff, or number 16, which is contagious disease screening, and this is what I'd like to focus on because this is the work that I did overseas in Bangkok and the Thai-Burma border, and then what we do here as standard resettlement screening agencies, which there are 4 of in Colorado, that do standard refugee medical screening here. So what's involved in the process? This is done by International Organization of Migration, UN, medical evaluation. So you go down that long list of all those things that I showed you from the New York Times infographic, And then you finally, 6 months before you get to come to the United States or another country, you have your first full head-to-toe medical evaluation. And it includes screening for inadmissible health conditions, which include active tuberculosis, infectious, active drug abuse. So they actually get people into treatment and try to get them stable before they're sent on a commercial airline. The goal is you don't want to infect someone on a commercial airline with something that can be treated overseas. And this is what I'm going to focus on, and we'll go through 3 weeks before departure. Burmese and other refugees will also get another evaluation by IOM physicians. And then 24 to 48 hours before departure, they'll be screened again to make sure there's nothing going on, active diseases, chickenpox, measles, etc. And we'll also get medications, presumptive treatment for soil-transmitted helminth infections and strongyloidiasis, which is a ubiquitous infectious disease. And this is specifically focusing on Burma. It's a different approach for sub-Saharan refugees. So I have to say I feel really incredibly fortunate to have been able to go work with IOM in Bangkok. And so I met a group of physicians. This was through Centers for Disease Control, University of Minnesota, and IOM in Thailand. And this is first what we did. We worked with this very large group of more than 25 physicians and healthcare workers who all are employed by IOM around the world to do these medical evaluations that I just showed you overseas. So we met with physicians from Jordan, Syria, Afghanistan, Nepal, Ethiopia, Sri Lanka, etc. I could have spent days talking to each of them about their different issues that they are dealing with. The Jordanian pediatrician who was doing Syrian refugee screens, now not for the U.S. because we are not accepting any Syrian refugees. And so we spent several days doing trainings with them. And the issue is that most of these physicians are not pediatric trained. However, over 40% of refugees who are resettled to the U.S. and other countries are pediatric. And so I'm a general pediatrician, and so they asked me to go over and do pediatric-specific training to identify malnutrition, et cetera. We also were trying to get standardization of examinations. You know, in physicians do head-to-toe exams. You do the same things over and over again so you don't miss things. This is also to do training to make sure, as I said before, that children and adults are fit to fly. They're not contagious. They're not unstable, where they have unstable angina, where they could get sick on the plane. And then also the challenges of signing out complex medical cases. The most complex case we've had to come to Colorado in the past 5 years was a Rohingya refugee who had end-stage renal failure, who was being dialyzed every several days. How do you get such a patient, from Bangkok here and get them dialyzed? So medical transport, signing out the case, getting hospitals coordinated when they land here from JFK, getting them to the hospital and getting them dialyzed so they don't miss treatment. So these are incredible challenges and multinational efforts that go into this. This is a picture of, we had hired Thai patients. So this is a pretend patient who has scripts that he's doing in Thai. We have a Thai nurse who's serving on the left as an interpreter. And the gentleman on the right is a Nepali physician who has several other physicians observing this poor man, making sure he's doing everything he's supposed to do. So this was the setting. So again, there are many challenges for the IOM physicians, and I actually learned about more of them, because one of the things that we do is when we do standard screenings at one of the screening sites across the country, and one of the 4 here, is we get medical documentation from overseas with that IOM physician's notes. The problem is that refugees, you saw the infographic with how many years it takes to get refugee status. You're finally going to get on your plane. You have 6 months that you're going to get evaluated, 3 weeks, and then 2 days before you're going to get on that plane. And you do not want anything to get in your way. And there's a perception with a lot of refugees that if a disease is discovered, that they're not going to be able to come. And so all of the IOM physicians told me, yeah, if people have chest pain, they often won't tell us. If they have any concerns, they won't tell us. And so from our end and our perspective, when we get them, they're like, why did they miss this? Because they're suddenly in our rooms and we're examining them and they're telling us everything. And this is some of the reverse perspective that I found incredibly valuable. The other thing is that, the Jordanian IOM physician or the Nepali, they don't have access to health hospitals as we do. And while these refugees are waiting in their camps or in urban areas, because they're urban refugees as well, how do they get access to subspecialty referrals and evaluations? How does the IOM physician who happens to be stationed in Thailand and is from Bangladesh, and I'm not kidding, and cannot read Thai, access the Thai hospital records and understand what was done? They don't. Okay, so this is where it gets really complicated. And then they shared with me, and I was really surprised about this, I get 20 minutes for my visits, and so do they. So it's pretty tricky to do this. So after the training in Bangkok, we flew to the Thai-Burma border. And it's probably one of the most beautiful settings I've ever seen. Very rainy, incredibly green. And this is where most of the Burmese patients that you're seeing here are from. How many people take care or have seen Burmese refugees in some setting? Okay. So it's stunning, but there are lots of issues. So this is your geography quiz. Or not a quiz because it's here, but this is what you're going to remember. I had my kids look at this last night. So as you can see where Bangkok is down, I don't have a pointer, but it's by the Gulf of Thailand. We flew up to the Thai-Burma border. And again, I wanted to point out on the western side of Burma, or Myanmar, is Sittwe province, which you may have heard of, which is the main city where all the Rohingya were expelled from, and they ended up in Bangladesh. Okay, so that's in a place called Cox's Bazar, which is an area that's just sort of became a de facto refugee camp. This is not the population that I'm talking about. This is ethnic Burmese who have fled from Burma and were living on the Thai-Burma border on the east. The other point I wanted to make is that's one cohort of refugees from Burma. The other refugee group goes to Kuala Lumpur in Malaysia. And I want you to remember that, and I'm not going to focus so much on that, but I do have data on differences between health of those who are in Thai refugee camps and those who end up in Kuala Lumpur. And we see both of those groups here. This is a really busy slide. I'm very sorry. My kids saw this last night. They were like, Mom. So here's the Thai-Burma border, and you can see the dots. The largest dot sort of in the middle on the left is the Mae La Refugee Camp, and that's the largest camp in Thailand, and that's the one that I visited. And then there are 8 other camps in Thailand, and Thailand doesn't want them to be there. We're talking about a very mobile population. They've been subjected to ethnic and political conflicts over years. There's lots of human rights violations. There's over 500,000 internally displaced people in eastern Burma. There's over 100,000 refugees in camps in Thailand, and Thailand does not want them there. There's approximately 300,000 mobile and migrant workers in Tak province, and Tak province is around where the Mae La Refugee Camp is and where we were. And there are over 3 million migrant workers living and working in Thailand. So brief history. So it was Burma was a British colony. It gained independence in 1948. There was military rule until 2010. In 1988, there was a huge student uprising, suppression, and killings and efflux to Mae Sa, Thailand, and other refugee camps. There was a relief center that was initially established in 88 through 94 to allow for cross-border referrals. Mae La Refugee Camp was established officially in 1998. In 2004, the first Burmese refugees came to the United States. I want to give you a little bit of a perspective of what health in eastern Burma is in 2004, 2013, Burma nationally, and then Thailand. Because this sort of gives you the backdrop of the refugees that you're seeing who are coming from the camp, but also the population. There's a very migratory and porous border between Burma and Thailand. And there is very serious issues with health and public health issues as well. And the other issue is that since 2005, Thailand has not been given refugee status to the migrants that are crossing from Burma. So they can no longer get refugee status. So we're only talking about the people who have been in Mae La Refugee Camp for the past 20 years or until 2005 who are still coming here. So if you look here, infant mortality in eastern Burma was 91 per 1,000 live births in 2004, 94 in 2013. This is a really stressed area compared to national Burma and then to Thailand. Under 5 mortality, significant differences between Eastern Burma and Burma in general, and obviously for Thailand, and child malnutrition also. So this is a very stressed area. This is a photo that I borrowed from the head of the Mae Tao Clinic, which is a clinic serving migrant populations that we also visited at the Thai-Burma border. And this is showing migrants fleeing Burma during the refugee crisis. Just to give you a little bit of background on resettlement of refugees. So from 2008 to 2014, and that's the most recent data there's over 100,000 Burmese refugees that have resettled in the United States. The majority are from minority ethnic groups, and they're listed here. Rohingya is not on the list. We don't have that many. I wish we did. And then this is the division between who's fleeing to Malaysia and who's fleeing and getting into Thailand. And again, this affects health here, and I'll show you some of that data in a minute. This is primary resettlement data of refugees during this same time period. Colorado is sort of a middling state for accepting Burmese refugees, and this is primary resettlement. You'll hear this term used in the resettlement communities and refugee populations. There's primary migration and secondary migration. People are used to migrating, so you get to Colorado, and the goal is to resettle people with others in their community, so you're not brand new and there's no one else in your community, but you might have a cousin who lives in Texas, so you might move to Texas, or you might move elsewhere. And then this, I wanted to take a step back, and again, what Dr. Berman was mentioning in the beginning about who we're accepting, because again, I know that this is just an example of a population that we serve. This is fiscal year 2018 on the left and 2017 on the right with primary and secondary arrivals, and I've highlighted a couple things. Burma, you can see listed and how many we've accepted each year. The ones in blue, if you compare from 17 to 18 with the executive order and the ban on certain populations coming to the United States, Somalia has dropped to basically nothing, Syria to nothing, Iraq to nothing. And then I also wanted to highlight El Salvador, Guatemala, and Honduras. None of these children and adults are very few are getting refugee status, and that's a whole nother talk. But it's pretty alarming. And so none of these children and adults are getting legal status in the United States, even though they're fleeing essentially war-torn from drug trafficking. So let's go to some cool pictures because I like pictures. So we landed in Mae Sot, which is the main town in Tak province on the border. And then we drove through the most lush, gorgeous countryside. And so we took pictures as we went. And then you can see this is actually the Mae La Refugee Camp, and it's in motion. And the reason why it's in motion is the Thai government would not let us take pictures. The Thai government actually had military following us through our entire tour. We were not allowed to leave where we were walking. We could not talk to any of the refugees. They do not want the camp to be there. There's been negative PR about suicides and the like. And so we surreptitiously took pictures, and then I took some off the web. So it's a very concentrated population. The other thing I'll point out here is the camp has been in existence for 20 years, and there are no permanent structures. That is by design. They don't want the camp there. So the IOM facility that we visited where they were doing tuberculosis treatment had no walls. It had a thatch roof. It's intense. And also stunningly beautiful in the area where it is. So this I pulled off the internet because I couldn't take pictures otherwise. And this is sort of what the camp looks like. So kids walking around barefoot, so there's risks for strongyloidiasis, there's risks for chronic soil-transmitted helminth infections, and this is all things that are treated overseas by IOM or screened and treated for when they arrive here. This was incredible because everything is thatch and there's no fire department. Every hut has little baggies with water and sand just in case things catch on fire. So let's talk about the camp a little bit more. 50,000 refugees, most of them are Karen ethnicity. The average length of stay is 10 to 15 years. We have multi-generational camp dwellers. In fiscal year 2019, 4,000 refugees have been accepted for resettlement in the world. 4,000 in the world out of 50,000 refugees. That's the annual average. That's not just the U.S. It's the largest camp, as I said. It's funded by UNHCR. There is one hospital there and clinic. It's run by International Rescue Committee. We visited that. The options for those who are living there are repatriation to Burma, resettlement, or stay and hope that the Thai government doesn't close it down. In fiscal year 2018, out of 50,000 refugees, 70 returned to Burma. They cannot leave the camp for work. There are no permanent structures, and since 2005, no refugee status is allowed. We visited the clinic and hospital run by IRC that also has no walls. There's one physician who gave us a tour. He was the inpatient physician for 80 inpatients. We really didn't want to bother him and really didn't want to waste his time, I can tell you that. And all of us wanted to actually jump in and help. There's 70 deliveries a month. Dengue fever was very active then. TB also. Malaria, actually non-falciparum malaria has become under control actually because they're using netting. There's lots of chronic malnutrition. HIV and IV drug use has become an increasing issue, as has suicide. There are, as I said, 9 refugee camps in Thailand, and this is data from CDC. 2% of kids have acute malnutrition or wasting, and it's lower than rates in Burma. But 40%, and the range is there, of looking at all the 9 refugee camps, have chronic malnutrition or stunting, and it's higher than in Thailand and equal to those in Burma, and we see this here. The immunization rates in less than 1-year-olds are listed, so BCG has pretty decent coverage, OPV and DTP. So what's this? Measles. So you can get it in Stapleton. You can get it in Boulder. You can get it at Disneyland, but boy, can you get it here, because in Burma, the vaccine rate is really dismal. And as I told you, it's very porous. This is one of the posters actually in the main general hospital that we also visited in Mae Sot. This is more data. Reproductive health and gender-based violence in Thai refugee camps for almost a year in 2014. I put arrows where I think it's sort of interesting from a screening standpoint. So syphilis screening during pregnancy, 68%. So there's a significant chunk of women who aren't getting screened for syphilis, and if they have it, they give it to their baby, and then you come here and you can have congenital syphilis, and so we need to screen, okay? Abortion complication ratios. This is the number of abortion complications per 1,000 per month, 67. I highlight it because in Thailand, abortion is illegal, and so this is abortion complications from people trying to self-abort. Contraception prevalence rate, 42%. So again, when we get refugees here, and we're really trying to get nationally to get people talking about this and also standardizing this in Colorado, is when someone comes, you know, when was the last time you had sex? Did you use a condom? Probably not, because you had no access to it. Do I need to give you emergency contraception? And it hasn't been discussed very well. I think people are really hesitant. I'm not sure why. And so we're trying to really get people to do this, because unwanted pregnancy is a big deal. And I'm not going to talk about the rest of this. I mean, gender-based violence is an issue. I think it's incredibly underreported because it's stigmatized. So this is IOM Mae La Refugee Camp data, actually most recent, January through July. I was there in August, so this is very recent data. So out of 153 patients they screened, there was a 4.4% rate of hepatitis B. It's a high prevalence country. And this then includes concerns like vertical transmission, which has the highest rate of developing chronic hepatitis B, and then hepatocellular carcinoma and death in people as young as 30. So we're missing this nationally, vertically transmitted infections and the importance of screening young children. Pregnancy rates high. Non-falciparum malaria, low rates. In their 123 people they screened, there was no HIV, syphilis, or Hep C, but Hep C is becoming more of an issue because there's more IV drug use. And this is getting back to the data that I was telling you about with health conditions in children that we looked at, because my bias obviously is peds, but is looking at Thai refugees versus Malaysian refugees. And the Malaysian refugees tend to do better. And I think partly they're in an urban area so they can find work, even if it's illegal, so they can buy food. And in Thailand, they're not supposed to work. They're stuck in this camp. They're in very close quarters. And so if you look, and this is some work that we did and published in American Journal of Public Health, is elevated lead is more of an issue in the Thai refugees than the Malaysian. Anemia is more of an issue. Hepatitis B is significantly more of an issue. TB is the same, and strongyloidiasis is more of an issue. So if you see these refugees and I ask, where are you from, Malaysia, or are you from Thailand, it really kind of helps me guide, or at least sort of take a step back and think a little bit about more of what I'm going to be dealing with. So this is a picture of me. I'm standing on the Thai side of the border, and it's separated. That's Burma on the other side. We were so close, and I really wanted to go over, but we had no time. But it's very porous, and you can walk across, and you can float across. And so these are refugees who are coming over, or migrants. And what I'd said before about how since 2005 no one can have refugee status anymore is that this is now migrant folks who are settling in Thailand because the health is better, health access is better, job payment is better. Does this sound familiar at all? I mean, it was a little eerie because we had tours of the general hospital, the clinics. And there was a lot of discussion about border issues and porousness of borders and taking away care. And I sat there and I was like, oh my God, I feel like I'm in the United States right now. But this is their reality. So these are migrants. And they have no legal status. This is a family that's waiting at the Mae Tao Clinic, which services 50% of their clients are from Burma and 50% are from Thailand. And this is the pediatric clinic, where the ubiquitous way to weigh little babies. I kind of like that. And so the Mae Tao Clinic, and again, I'm taking a step back, I'm giving you an idea of what the public health is in that community, not just for refugees. In 2017, they saw 50,000 patients, half Burmese, 9,000 less than 5, 18,000 women of reproductive age, 100,000 consultations. They're running on donations. It's not funded by the Thai government. 83% with no insurance. And in 2016, they established HIV cross-border referral and MDR and XDR-TB referrals. And boy, is it complicated, because Burmese the government doesn't want to officially establish ties, so they have to make referrals through the capital and hope that they can get those patients seen. This is from the head of Mae Tao Clinic. And again, I just think it's really interesting to compare the barriers for accessing care in Eastern Burma and Thailand to our barriers, and they're pretty much the same damn thing, just a little bit more complex. So they also have looked at infectious disease, and they compared 2013 to 2017. So this is giving you an overall better picture of what it looks like at the border on either side. HIV in children and adults, they had 103 cases in 2017 with a variation increase of 37%. TB increased, more HIV testing and counseling, but less malaria, which is great. Child health. again, because of my bias. Moderate and severe malnutrition, a really significant bump. Heme disorders, mostly iron deficiency anemia. Lower respiratory tract infections and bloody diarrhea and watery diarrhea. And the reason why they give these categories is they don't have money to do all the testing. So they had admissions, and I asked, so do you guys have access to comprehensive metabolic panels, BUN, creatinine to check kidney function? No, they don't. And so they just do very basic testing and hope and treat. And so this is a picture from their clinic. They have refugees who, ran into mines, and so, had to have amputations and then prostheses made. This slide actually is really interesting. So in 2009, the Thai government finally allowed refugees and born in the camps and any babies born in the general hospital to get identification cards, because before that they weren't allowed it. And without an identification, you don't know date of birth, you don't have any right to anything. And I don't know how many of people in this room have seen refugees who have assigned dates of birth of January 1st. How many people have seen that? It's really common because people don't know their dates of birth, and it's not just Burma, it's in Africa as well. And the problem with that is you estimate, and boy, is it really difficult when you have someone who they say they're 15, but in fact they haven't had puberty yet and they're put in 10th grade in high school. And we've had this happen in Colorado. So Mae Tao Hospital is the general hospital, and this is looking again at HIV because it's becoming more and more of an issue. And they have been working to develop this cross-border referral network, which has been very difficult to do with a very closed Burmese government. So they referred these numbers of patients back with HIV because they go back and forth over this time period. And then some of them, and they've tried to track how many have received antiretrovirals, but there's a significant number who are lost to follow-up. So tracking is difficult because people are moving all the time. So I want to get back, sorry for all the graphs, because I really like patients a lot more. So I want to get back to like the humanity of this. So here's my family. So they were born, the woman and her sister, not the baby, were born in Mae La Refugee camp. They fled. They lived there for years. They had very little access to school, and then made it here. How did they get there here, and what's their experience? So again, getting back to their screening, 6 months before departure, they get on a bus in their refugee camp, and that's the bus. And they're driven from their refugee camp an hour back to Mae Tao, the town, to the IOM offices. And there they get TB testing at these age ranges. They get a chest x-ray for that age range, and they're only looking for active contagious tuberculosis. They're not worried about latent TB infection. They get screened for hepatitis B. That's actually new in the past couple of years. They get tested for gonorrhea and chlamydia at the age range listed, syphilis. They're not doing HIV testing because of the stigma associated with it. Since 2010, people were so scared, and it is not inadmissible because it's treatable that they just stop doing it, and we do it here when they arrive. They do a past medical history checklist and the physical exam that we worked with the IOM physicians in Bangkok to standardize to try to get them better at picking up malnutrition in children. They get minimal vaccines, and they get presumptive treatment. So we call it the cocktail. 24 to 48 hours before they get on a plane, they get albendazole and they get ivermectin to treat presumptive soil-transmitted helminth infections that has very high rates, and strongyloidiasis, which also has high rates. So there they are on their bus. And they come to the clinic, and this is the first time they've been to a clinic with walls. I mean, this is incredible. So this is in Mae Tao, okay? This actually is their TB sputum collection center. And then when they get on the bus, after the 6 months, they go back to the refugee camp. 3 weeks before, they go back, they get screened again, they go back to the refugee camp. And then if everything's good, 48 hours before departure, they get brought here. And they're in Mae Tao, in the town, where they sleep in beds, and they wait to go, and they're screened to make sure they don't have measles, that they don't have chicken pox, they don't have anything, because if they do, they're held longer. And so again, they're not going to tell you, unless they have rash all over them and you can see it, they're not going to tell you they're not feeling well, because they want to get on that plane. They get a bathroom. And I have to tell you the most bizarre thing, and I could not find a picture of this, and we all talked about sneaking a picture in the refugee camp. There is a model kitchen and bathroom that's walled off with plexiglass on one of the main roads in the refugee camp that refugees can look at so they can learn what maybe they'll get. It is the most bizarre thing I have ever seen. Some teaching. And then they get on the airplane and they go to Bangkok, and here they are, and then they show up here. And oops. And what a change. And can you imagine being in their shoes and doing that? I can't. And then we see them. So they are resettled and linked to either International Rescue Committee, Lutheran Family Services, or African Community Center, which are the 3 resettlement agencies that exist in Colorado. Every state is different. And they get a refugee screening exam. There are 4 sites that I mentioned: Denver Health, MCPN, Peak, and so those are both Metro. Peak Vista, which is down in Colorado Springs. Sunrise is in Greeley. They take very few, but they do see them. We're trying to standardize screening so everyone gets a vision, because guess what? They're not getting it overseas. So anyone who shows up here, you assume they've never gotten anything, right? As a physician, any kind of provider. They get a hearing test because they've never been checked, and no one's going to tell you that they can't hear, because children don't know they can't hear. Right? We're trying to get everyone to do blood pressure standardly, because it's not done, and renal anomalies and et cetera can be missed. Vital signs, head to toe exam. You look at everything, because they've never really been completely examined. And then this is what we've standardized for the state, and it's a little bit interesting, and it's a busy slide, but every state kind of does this differently. We're trying to standardize this nationally as well, and these are through CDC guidelines. Everyone gets anemia and parasite screening. Everyone gets a lead 0 to 16 in women of childbearing age, because a woman with lead who gets pregnant makes a fetus that has neurodevelopmental problems in a big sort of way. They get tested for TB. They get a hepatitis B panel. We're doing C in everybody. There's not great data nationally and internationally of hepatitis C prevalence. The studies aren't very good. So we are, as a state, probably over-testing, I have to admit, but it's a little hard to decide who and who not to screen. We test everyone for HIV, syphilis, depending on risks, gonorrhea and chlamydia. We do newborn screens on babies who arrive and they're 1 or less. And we got the state of Colorado to agree to this, because no babies overseas are getting newborn screens. We're looking for iodine deficiency and congenital hypothyroidism by checking thyroid function in that age range, pregnancy tests, and depending on what they receive overseas, we'll test for strongyloides and look for soil-transmitted helminth infections if needed. So, in conclusion, the U.S. is at an all-time low for number of refugees that it accepts for resettlement. There are significant public health challenges at the Thai-Burma border that impact the population in resettling refugees. There's a moderate-sized Burmese population living in Colorado that is made up of multiple ethnic groups. Refugee designation and resettlement is a complex and multi-year process. And finally, if you're seeing former refugees in your practice, or you think they might be refugees, ask them. They know. I promise you they know. It took them years. And if you have questions about prior screening results, overseas records, contact the Colorado Refugee Services Program. You can Google them. I didn't want to put their number up because I think they would have killed me. But you can contact them directly, and they can get records if you're actually seeing the patient. I want to thank colleagues both in Minnesota and the CDC and in Thailand. And then finally, I just wanted to point out, if you are really interested in refugee and immigrant health and all these issues that have come up recently and chronically, is the North American Refugee Health Conference. Happens every year. It's going to be in Toronto in June. It alternates between the U.S. and Canada. It's great cooperation, don't you think? It's probably one of the best conferences I've been to, and it's multidisciplinary, so it's not just physicians, it's public health workers, it's nurses, psychologists, etc. The CDC domestic refugee screening guidelines are excellent. They have refugee health profiles, and they also outline a lot of this information. You can Google that. And the AAP, American Academy of Pediatrics, has a really good immigrant toolkit. So with that, I will end, and thank you so much, and I'll take questions. No questions? Yes?
If you're a Burmese refugee, how do you get to Malaysia? How does that group get there instead of Mae Sao?
Boat, car, walking, bus, flying if you have the money. Yeah.
Do you know it's better to go to Malaysia?
They don't. I think it's people who probably tend to be more educated and have more access to funds can get there as opposed to just walking across the border. So that also might impact health in general, right? But good question. Any other questions? Jill.
So if they take away the being called a refugee in these camps, then isn't there flexibility in the way things work that they could be called refugees once they get somewhere else? Like, why does it have to be so rigid?
Right. I think partly because Burma is now considered more stable with Aung Suu Kyi, and that's a whole other conversation. But and so they're not considered as really at war anymore. Although there's still a lot of human rights abuses, from what I understand. I mean, if you look at the Rohingya population as well, right? And then other people are welcome to comment too, because I'm not the complete expert. I'm a medical provider, so but I think, you know, I mean, the Rohingya population, we should be accepting many more. They happen to be Muslim. So, and I don't make those decisions, unfortunately. So, yeah.
So is there any standardized, like the EPI program for immunization for these guys? For the kids in the refugee camps, do they get the expanded program immunization there? WHO will provide?
No, they will get vaccinations, whatever is available in the camp in general for wherever they're being seen, because they haven't been accepted by the U.S., by Australia, by Canada, UK. They're not being formally evaluated by IOM and getting those vaccines started. And their standard vaccination package that everyone should be getting, and we see that they get, especially kids, and as long as there's access, because it also depends on where we're talking about in the world. But there, since it's unfortunately or fortunately a well-oiled machine because it's been there so long, they tend to have good access to vaccines. But if they're just in the refugee camp and they haven't been accepted yet, it's sort of, you're at the mercy of whatever the IRC, the International Rescue Committee funded hospital can supply. Yeah. So it's a big deal. And I mean, you know, so then we see refugees who come here and we get them vaccinated, and then we have an entire U.S. community that doesn't want to vaccinate. Anyway, that's a whole other talk too. So, yeah. Any other questions? Yeah.
If they're found to be chronically malnourished just before they leave, what happens?
So
Does that make a difference? Does that prevent them from coming?
If they have severe malnutrition, they won't get on the plane, and they'll get treated before, so they'll get stabilized so they, you know, don't get very sick and get refeeding syndrome and that kind of thing. There have been cases where it's been missed, and this is thus some of the training that's been going on to get IOM physicians to plot growth charts and look at malnutrition, and because it unfortunately hadn't been standardized, and then also the issue with dates of birth gets in the way. When you plot a kid on a chart and they're the wrong age, they might look okay, but it's sort of trying to figure out who's really malnourished just by looking at them and who not. But they won't, you know, the policy is if anyone's unstable, they won't get on the flight. So we get moderate malnutrition and mild malnutrition, and then also a lot of chronic stunting and multi-generational stunting. And so the problem with that in pediatrics is that If a parent is stunted and the child is stunted, we've been trained to look at, if you look at a child growing over time and their height, you look at the parent's mid-parental height, you look at the predicted height by virtue of the parents' heights, but the problem is that the parents are also stunted. It's really hard to interpret. So you're sort of assuming they're chronically malnourished and stunted, and then you have to figure out who you actually have to work up for something else, like growth hormone deficiency or something like that. But the vast majority are going to be stunted because of chronic malnutrition. So the good news I'll say is that in the kids who are stunted, the ones that we feed here, they get access to food, great, they start eating, is we'll see their height start to pick up. They won't get to their predicted height, but at least they start growing. And so that actually helps us a little bit if we can follow them over time to decide who we're going to work up and who we're not, if that makes sense.
Yeah, just curious. We've heard in Colorado from the refugee serving community that this ratcheting down of the number of refugees arriving in Colorado and the U.S. means that all these institutions and kind of institutional memory is getting lost. Have you heard that when you go to the international conference or other, that there's just so much specialized learning that's happened over the years, and it's just
the answer is yes.
Okay.
Yeah, I mean it's really hard right now, I would have to say. But I'm speaking on my behalf and no one else, just to be clear. So, but it's quite difficult, and funding cuts unless all the institutions here get paid by the number of refugees they screen, and so if you don't have the number of refugees that you've predicted, then you cut programs. So, yeah, I have to say though, it's probably the most awesome work ever. And these are amazing families. These are incredibly resilient families who make it here, who their kids go to school. In a year, they're speaking fluent English and telling me everything about their lives. And, the parents we all would do the same thing. We want opportunities for our kids, period. And so if we were in the same situation, we would all do the same thing. So I love what I do, and I think it's an incredible thing to do. So. Any other questions? Thanks so much for your time. Okay.
The mango, yeah. And artists moved, I think, across the street.